So in terms of the presentation structure, I'll just run through some context with the healthcare services and what that really means. There is a very quite different and a more complex organisation that most of our than most, say, let's say a local council or a city or an individual business. And I'll also talk about the outcomes. So I'll run through 3 items. One will be the actual model, the generation model, quickly talk about that, the initiatives, and then run through the waste management tools. So first of all, some context. 14.3 billion gives you a scale. That's per annum. That's the budget for the Victorian public healthcare service. That's, you know, a very substantial budget in anybody's language. The healthcare service is broken down. You obviously don't manage that with one organisation. It's broken down into a group of 90 healthcare services. They are then split into 5 levels. They're specialists, metro, regional, sub-regional and rural. And that really reflects the complexity of those organisations. You can't compare the Bright healthcare service with a major Melbourne metro hospital, so therefore they've broken it down and that impacts on their funding arrangements. They run 159 facilities collectively across Victoria, 2.5 million square metres of floor area, 250 hectares of land, of treatment space is what they occupy. And in terms of hospital activity, what we did find is the healthcare service has a very data-intense environment, and they used a variety of definitions. You've got to remember that they're constantly having to report back on activity back up to the state level and back up to a federal level to justify funding. So they had all the definitions you can imagine and more. So this measurement here, 4.4 million occupied bed days, was a measure of whether a bed was occupied at midnight. So if a bed was occupied at midnight, that means there was an activity, an occupied bed day. The separations was there a recorded medical event? And you generally would add those 2 together to work out a level of activity. The separations might be an emergency department. Someone comes in, is there for a couple of hours, and then goes out, so you needed to be able to record it. And so there's a whole variety of these definitions, believe me. In terms of, again, building on that context, in terms of the levels of waste, you can see here that there's a whole range of fairly typical waste types, particularly starting at the top. You've got the recycle, the reuse type symbols that are used, and these are the actual Victorian Department of Healthcare standard symbols that they use. And then towards the bottom, you'll see that there's a couple of ones that you won't have seen very typically, clinical, cytotoxic and radioactive. And that's where the complexity came into the equation. So again, in terms of talking about the waste, we end up dealing with upwards of 17 different waste streams, and the ones who have picked up the detail, they'll see that there's there are more waste streams than there are labels in there, and that's simply because there are things like e-waste, there are mattresses, there's a whole lot of other waste streams, packaging, pallets that we recorded in our analysis compared to actually the standard array of symbols there. 62,000 tonnes of waste generated per annum, 1,500 tonnes per annum generated of clinical waste, costing 10 million per annum back in 2006-2009, with this, by far the largest proportion of that being the clinical waste, which is $3.7 million. So that just gives you sort of a context, the scale, complexity of what we were dealing with as a Victoria-wide organisation, and the complexity of the waste and what was being undertaken. So let's talk about the study outcomes. So I want to talk very briefly about the waste generation model. I'll run through that, which will just give you some idea of what we did and how we did it. So we developed this model, and I've put in this flow chart here. I've tried to keep it very simple, again, like Joe. Data dense, enormous amount of data was brought in we brought in 23 waste services, probably 100 hospitals, all brought in their data. It was all different, it was all different definitions, it was all measured differently, so we had a whole lot of conversion having to be done to that data, some conditioning of that data. But if we talk about just briefly about the model, just to give you an idea, so the first one you'll be able to see there is the measure of the waste generation rate. So we tried to, again, we're trying to get to a situation at the end of the project where we could project the level of hospital waste, because we're really talking, again, at pretty much a helicopter view. We're trying to understand what is happening with waste generation from a policy point of view. So we developed waste generation rates for the various types of waste and the various levels of hospital, because it was going to be different with each one of these hospital types, the 5 levels I spoke before. Once we'd set that up, we then were able to work out the waste generation rate for hospital level, and then we're able to project that out to 2021 using standard growth rates. So it was a fairly sequential, sounds really great in a 30-second spiel here. It took 6 months for us to do that. So, you know, it's not as simple as it sounds. Parallel to that, we created, and we were given all the costing data, we were able to work out the cost rates for the various types of waste. Important probably to highlight that whilst we had 17 waste streams, we end up classifying those down to make it far more usable and just into 3 types. So we spoke about general waste, clinical waste and recycled. So we basically took those 17 wastes and then classified them into one of those 3 and then applied it to the 5 levels of the hospitals or the healthcare services, just to make it far easier to analyse that data. And you'll see why in a minute. So you can see some of the outputs from this model, again, emphasising we're trying to operate at a fairly high level of understanding the costs that the healthcare services were facing. You can see that here's an annual general waste rates by waste type. You can see it's growing at about 5%, which was the standard growth rate in medical procedures across Victoria at the time. And you can see by weight, the greatest weight there was just the general waste. However, when you looked at clinical waste generation by per patient treated, which was a measure of activity by the health service level, again, probably no surprises in that the metro hospital certainly topped out in terms of the amount of clinical waste being generated. What this level of granulation, though, provided was about an ability to focus in, give us the right amount of level analysis to be able to then help the healthcare services focus in on where were the problem areas, or not necessarily the problem areas, but where could they apply, get the maximum bang for their buck, let's say. So some of the key findings that came out of that, again, we're able to project, again, these are very high level. There was 2 pages of findings just out of this section, but these are probably the high points. You know, 52,000 tonnes of general waste, $37 million by 2021. Clinical waste, what was probably the important thing was the cost of clinical waste. 2/3 of the total cost, 1/10 of the weight. So there was straight away, that was a focus point, and you'll see that coming out later on. What also came out of the model in discussions with the healthcare services was significant savings, and we did 5 or so scenarios, and it certainly highlighted the level of savings. We were able to identify about a $10 million saving out by 2021 by implementing some very simple initiatives. So let's just run through those waste management initiatives, and I'll just bring them up all on the screen. So firstly was improving clinical waste management practices, and what occurs in a hospital is there's let's say a precautionary principle is applied by the staff that actually, the ward staff. If they've got any doubt about any material having been contaminated, it ends up in the clinical waste bin. So generally they will quickly just, they're under time pressure, they've got to clean up a room, get a room ready for the next patient. You just don't have so much time is the real issue, and you just generally adopt the precautionary principle, it goes in the clinical waste bin. And that can be in a surprising amount of material just ends up in there. And it's quite surprising how much single-use material is now adopted by healthcare services in the wards. It really is curtains, everything. It's just single-use, doesn't get cleaned, it just gets pulled off and replaced. Recycling the medicals waste and metals from theatres and plastics and wards. again, so much surgical equipment nowadays is single use and goes straight, does not get cleaned, doesn't get reused. There's too much perceived in terms of cost, as well as risk of infection. So a lot of the surgery, your scissors, scalpels, a whole lot of instruments are just single use and go straight into the clinical waste bin. That was an eye-opener for our team. Food organic composting facilities. Largest kitchens in metropolitan Melbourne are the ones that service the hospitals in Melbourne. 150,000 meals a day are served. A staggering number of meals are presented every day, and there's a great opportunity for improved organics, composting and collection of food waste. Healthcare services in Victoria, largest user of paper in the Victorian government. Some staggering number of reams of paper are used. In this day and age, you wonder why, but that's the case. They're slowly moving over to electronic records, but again, an initiative in there that was identified. And another key thing was the effective management of e-waste. They have a huge, you imagine all those facilities, you know in your own offices, your own buildings, how many computers you have. You multiply that by the level of electronic equipment that's available in a hospital, and then how quickly that gets turned over. I don't know about you, but we seem to have acquired so many laptops in my family. I know in another 2 years I'll be under pressure to renew them because it'll be the latest i10 out or something out coming out. So they're under a lot of pressure with e-waste. So what I'd like to go is run through is, and the final deliverable, and it's really good to see that the health department, and Tiernan Humphreys was a real driver in the Department of Health for this project. He was a real believer that he wanted to have something deliverable as a real outcome for the health services. So we've provided these 4 service tools to help them, because the health services are, they all run as individual businesses, so they are quite separate. So by putting up these, he was able to, one, solve the problem that was spoken about before around definitional issues around waste, definitional issues of collection, and just getting a consistency of framework here. What we also provided was this health services tool, and I'll just open that up. So what we prepared was a fairly simple Excel spreadsheet which enabled each of the health service and each actually health facility to capture the volume of waste they were generating, the cost of that waste and the level of hospital activity. And from that we're able to produce a very simple one-page summary that used consistent language and consistent KPIs so that when they all came together they could compare the data, and that was the driver, was to actually get the healthcare services, which do come together regularly and have to report, and provide them this tool that enabled to compare how they were going. So the tool was set up so that we could prepare 2 really benchmarks, and that was the tonnes per patient treated, or the kilograms per patient treated of waste, and the other one was the cost per patient treated of waste across the 3 types of waste. Again, I provided that link. Given the time frame, I won't go through the rest of it, but it's certainly available. You can download it, and it's there to be used. It allows the users a lot of flexibility in terms of the waste types. They introduce the invoice values, the cost of their waste invoicing. They're allowed to put in, they might have tonnes of waste, they might have bags of waste. It allows them to put that all in, and then it converts that for them into using standard conversion factors. And then they're able to put in their hospital activity. So therefore, we're very confident that they're getting a consistent benchmark at which they can compare each other's performance to. So I won't go through the other specification clauses. I had no intention to, because you need to probably just go and read those if they're of interest to you, but they were prepared and they've been used in their contracts as I understand it. So just in closing, the takeaways from my point of view in terms of the study was that sound decisions really do require credible and consistent data. And again, that's the second time you've heard that today with Joe's talk before. I think we probably underestimated how complex healthcare facilities are. They really are very, very complex in terms of the level, the people, the complexity of the environment they operate in. Certainly the modelling identified clinical waste was the key cost and was the key opportunity. But equally, I mean, we talk about the modelling, the consultation was with the people. The people had the solutions. They really knew what the issues were and were able to identify that, and through discussions with that, bring that out and come up with the initiatives. I'll call that to a close. Thank you very much. And I might, we'll leave questions till the end, I suspect.